Okay, welcome everybody. I know a lot of you, for some of you, it's the end of the night or the end of your day of work. Some of you on the West Coast are having dinner or about to. Probably have watched or been on about 4, 5, 6 Zoom meetings today. So I appreciate you taking the time to join us. And I want to welcome and thank Dr. Walter Tatch to make his time to be available for our membership. And thanks Stella Life who introduced me to Dr. Tatch. This is all about how dealing with pain management, which is very critical today in dentistry. I'd like to introduce Dr. Tatch, who's a board certified oral maxillofacial surgeon, graduate of University of California at San Francisco and University of Illinois at Chicago. And he's a fellow of many organizations, including the American Academy of Cosmetic Surgery and the American College of Oral and Maxillofacial Surgeons. And like most of us in this organization, he's dedicated and devoted his career to excellence in patient care and comfort. And he is a very frequent speaker at many local study clubs and many professional meetings. And he's currently practicing like us, or not practicing. I mean, he's practicing and seeing emergency patients in Chicago, in Illinois right now. So with that, I want to welcome and thank Dr. Walter Tatch for being here.
Thank you, Dr. Farber. It's a pleasure to be here today, and it's a pleasure to speak to your audience. The topic of my today's presentation is opioid prescription, in fact, opioid prescription reduction in dentistry. So what we're going to do is we're going to review pain management that's available right now for us in dentistry, and also I will share our personal experience in my practice on our quest of reducing opioids for our patients.
I forgot to mention that if anybody wants to, Dr. Tatch said if you want to ask questions during the program, he wants to keep this informal, and you don't have to wait till the end of the program, but you can go ahead and, I guess, interrupt him or hit the chat.
Dr. Farber, you can interrupt me anytime if there's any questions, especially during the presentation. I'd like to disclose my affiliation with Stella Life, as you mentioned. So pain management is extremely important in dentistry. It's no surprise that dental appointments are associated with a lot of anxiety. It's anxiety of pain, anxiety of dental procedures, anxiety of local anesthetic injections. So it's no surprise then that dentists have been at the forefront of pain management pretty much from the beginning. There's a lot of contribution by dentists to the anesthesia and modern anesthesia as we know it. And it also is no surprise that opioids, when they became available, were incorporated into dental practices for pain management in our everlasting quest to control pain for our patients. There's been a lot of discussion and talk about opioid crisis and National Institute of Drug Abuse. Just want to share their latest publication there under the umbrella of NIH. And their recent findings, recent publications, is that 130 people die daily in the United States from overdosing in opioids. That's an astonishing number. That's over 48,000 deaths every year from opioid abuse. But 25% of those patients are chronic, are patients who were prescribed opioids for chronic pain and ended up misusing them. It's interesting that 4 to 6% of those who misuse prescription opioids actually end up going into a much more dangerous drug such as heroin. And about 80% of patients who actually abuse heroin ended up starting with prescription opioids, which can be considered a gateway into the much more dangerous drug abuse. There's no question that opioid abuse is on the rise. There's about increase of 30% of opioid overdose in a 1-year period from 2016 to 2017 has been published by NIH. In most of the states, and Midwestern region for some reason has had the biggest increase, about 70% in the same time period. This is a survey that was published by Journal of American Association of Oral Maxillofacial Surgery, and essentially what they did is they surveyed patients who underwent oral surgical procedures. They sent a questionnaire afterwards, and part of the questionnaire was to elicit their experience with pain management, specifically with opioids, and they wanted to know if patients had any adverse drug reactions. And 90%, astonishingly, significant number, 90% of the patients who took the opioids for postoperative pain management after oral surgical procedures actually reported adverse drug reaction. Constipation, vomiting, nausea, and confusion were listed as top side effects. Interestingly, that 70% of those surveyed also said that if they had a choice, they would prefer a non-opioid option. And one of the reasons they cited is the obviously adverse drug reaction, but also a potential of addiction and abuse, and their fear of getting addicted to opioids. So there's no question that our patient population are looking for alternatives, looking for opioid-free pain management for their dental procedures. This is a flow chart here that's kind of summarizes pretty much all the recent and not so recent advances in pain management. The current pain management model that we're currently utilizing in the dental practices has been actually in place since 1970s. So it's opioids, non-steroidal anti-inflammatory medications, acetaminophen, and the adjuncts. And if we take a careful look, it really hasn't been any advance, anything new that came on the market that was available for us or is available for us for pain management for the last 50 years. In 2000s, we added gabapentin, which is good for neurogenic pain, but certainly doesn't have much use in the post-operative pain management. Exparel is an interesting new addition. In 2016, it was FDA approved for oral surgery. The initial research was done on hemorrhoid patients and found some efficacy. Essentially, what Exparel is, for those who are not familiar, is our local anesthetic bupivacaine in liposomal form that's designed to hang around the tissue for a little bit longer period of time and provide up to 72 hours of local anesthesia. Analgesics in general are classified as opioids and non-opioids, and both have been known and shown to have centrally and peripherally acting modalities. If we look at the opioids, essentially they act as agonists at opioid receptors. So it's a family of medication that work at the specific receptors within the central nervous system. There's about 5 that's been identified, and 2 have been thoroughly researched and described. Mu and kappa are the more commonly or most frequently described. Mu receptor is the one that's associated with undesirable side effects such as respiratory depression, dependence, and lethargy. The kappa receptor actually mediates analgesia and respiratory depression. Unfortunately, the efficacy is somewhat limited. Some of the studies, interestingly, have shown that 5 to 7 days may be enough for some of our patients to develop dependence. And that kind of cause for pause, really, because a lot of times our post-operative pain management is about 5 to 7 days after our tissue grafting, after osteosurgeries, after removing of wisdom teeth. So we have to be careful because there's a certain patient population that will develop dependence even during that short post-operative period. After repeated administration, patients will develop a tolerance to opioids, and we see it in patients who are coming to see us with a history of chronic pain. We know their pain management requirements are going to be much higher, and they will require much higher dosages of medications, of opioid medications, to control the pain at the same level. Pharmaceutical companies have created agonist antagonists, so they're agonists at the agonists at the kappa receptors, antagonists at the mu receptors, and they're available in both IV and oral form, unfortunately, the efficacy of those medications is not great, and they're not commonly used in private practice. So tramadol is an interesting medication. It has gained a lot of popularity, especially the last 4 or 5 years in dental practice, and we use it quite frequently, especially the last couple of years. It's a centrally acting analgesic with binary action, meaning that the parent drug and the metabolite exhibit clinical action. They're classified as a Schedule 4, and that's only recently, since 2016. Before it was not classified as a controlled substance in the United States. So Class 4, Schedule 4 drugs, as we all know, is something that has very low abuse potential. The parent drug inhibits essentially reuptake of norepinephrine and serotonin, and the principal metabolite, which is O-desmethyl tramadol, M1, demonstrate agonistic action at the mu receptors. So similarly so it does work on the opioid receptors. So with patients with any kind of history of opioid abuse, one has to be careful prescribing tramadol, because it can cause certain issues with those patients. So if a patient has history of opioid abuse, tramadol should not be given to them. Analgesic efficacy is approximately similar to Tylenol with codeine. And one of the recent findings that's been published the last couple of years is one of the side effects, if you will, is hyperglycemia. So patients who are diabetic should be taking tramadol with caution. And it doesn't seem to affect actually patients, general population, just diabetic patients. So if you're prescribing tramadol to your diabetic patients, you have to make sure they're doing their echo checks and making sure that they're controlling it well. Non-steroidal anti-inflammatory medication, the action and the side effects can pretty much be summarized in this diagram here. NSAIDs have been in dental practice for many, many years, and have, in my opinion, a huge place for pain management and anti-inflammatory properties. So the action takes place basically. It's a chain of reaction. The chemical and inflammatory stimuli stimulates the membrane phospholipids, which are then cleaved by phospholipase A2 into arachidonic acid. Arachidonic acid is further converted by cyclooxygenase into prostaglandins. Prostaglandins, serve a wide range of function in the human body. They protect gastric mucosa. They're hugely important in renal function, but they also are responsible for pain, inflammation, and fever. They also help with coagulation and important in the coagulation cascade as well. So the non-steroidal anti-inflammatory medications essentially work at the cyclooxygenase levels. Most of the medication that we use, most of the NSAIDs, are non-selective, meaning that they inhibit both COX-1 and COX-2 enzymes, and therefore we're seeing potential of some of the side effects that stem from the fact that prostaglandins are not generated, and particularly in the gastric mucosa and patients who have renal problems. Another pathway that can take place if cyclooxygenase is inhibited is that arachidonic acid can be converted into leukotrienes, and they can precipitate allergic reactions. So patients with history of allergies to NSAIDs, especially patients who have history of asthma, there seem to be a small percentage of those patients who are also allergic to NSAIDs, and careful medical history should be elicited when one prescribes non-steroidal anti-inflammatory medications. So when we go through the side effects, GI toxicity is probably one of the main ones, and that again has to do with the inhibition of prostaglandins that line in gastric mucosa. So patients with GI ulcers should not be prescribed the medications. Long-term use of NSAIDs can certainly create ulcers as well. Some of the studies and some of the clinicians have recommended PPI prescriptions if someone is taking NSAIDs for a long period of time. In our practice, it's usually 7 to 10 days for postoperative treatment. Sometimes patients with myofascial pain can be given it for a prolonged period of time. Now, it's important to say that selective COX-2 inhibitors are also available, to kind of mitigating the GI problems. Unfortunately, with the selective COX-2 inhibitors, there's been a lot of publications in literature the last couple of years, cardiovascular problems, and a few have been taken off the market. The bleeding is, of course, one of the side effects that is known with non-steroidal anti-inflammatory medications. And if one is if a patient is taking any kind of blood thinner, you definitely don't want to be prescribing NSAIDs in addition to it. Nephrotoxicity, I alluded to the importance of prostaglandins in the normal function of kidneys. So patients with reduction in renal function, patients on dialysis should not be giving any non-steroidal anti-inflammatory medications. Allergy, we've talked about that. NSAIDs should be avoided in patients in pregnancies, and that's because of its action at ductus arteriosum, and this is the only line where the oxygenated blood is taken to the fetus, so it can cause severe side effects, and pregnant females should not be given non-steroidal anti-inflammatory medications. And finally, NSAIDs have a tendency to interfere with the effectiveness of most of the classes of antihypertensive medications. So if your patient has a history of hypertension, they have to be given with care, and patients should regularly check their blood pressure. Acetaminophen or Tylenol is another medication that's very commonly used in our practice and has, in my opinion, a significant role. It's believed to inhibit prostaglandin synthesis within the central nervous system. Recently, a study identified a specific receptor, CB1, or cannabinoid receptor in medulla, where Tylenol seemed to exert its action. There's little influence on peripheral prostaglandin synthesis, and therefore it's a fairly poor anti-inflammatory actions. Tylenol gets metabolized in the liver, so patients with history of any kind of hepatotoxicity should avoid taking, or their dosages should be adequately adjusted. Usually it's half of what the normal dose is. Anyone with any kind of liver disease and stage liver disease, and patients with liver transplant should not be given Tylenol as well. And the safe dosages is about 4 grams per day. Some of the studies have shown 3,600 to 3,800, but kind of somewhere in that range. And patients with compromised liver function, that dose should be decreased at least to 2 grams per day.
Walter, I'm going back, quick question on NSAIDs in hypertensive patients. Is that an issue if you're just giving it for 24 to 48 hours?
It should not be. It should not be. I think it's enough just to warn the patient and to have them monitor their blood pressure a little bit more carefully. None of it, I think, for the short-term treatment, none of it is a big issue. Especially for postoperative course, that's only 4 or 5 days that we give the prescription for a couple of days. That should not really matter.
Thank you.
Sure. So what is the role of non-opioids in pain management, especially particularly in pain management in dentistry? And there's a number of studies that have shown that combination of acetaminophen and NSAIDs are generally superior to opioids at conventional dosages. This is an important graph that shows the relationship between pain relief and different dosages of medications. When we're looking at the opioids, and morphine is represented on this particular graph, we see a linear relationship here. So as the dosages are increased, so is the pain relief. Ibuprofen and or NSAID and acetaminophen actually exhibit what we call ceiling effect. So what is a ceiling effect? Ceiling effect is basically a dose after which any increase in that dose will not elicit any additional analgesic properties. Okay, for ibuprofen, it's 400 milligrams. So if we are comparing 400 milligrams of ibuprofen to 600 or 800 milligrams, the efficacy, the pain efficacy is about the same. Now, it doesn't mean that anti-inflammatory properties are the same. In fact, anti-inflammatory properties have little to do with analgesic properties. But when we're looking at purely analgesic properties, there is no difference between those dosages. And I'll talk a little bit about the rationale why I think it's important for the patients to use the minimal clinical dosage for pain management. There's actually two main reasons. One is that you avoid toxicity, you avoid patients overusing the particular medications. And number two is they can take it more frequently. So if you give the patient 400 milligrams, they can take it every 4 hours. With some of the studies have shown that in the past, we've always thought that maximum 24-hour dose of ibuprofen, safe dose, would be 2,400 milligrams. But some of the recent publications and studies are advocating about 12 to 1,600 milligrams. So, and one of the fears is GI problems and creation of ulcers. So if we're looking at 12 or to 1,600 milligrams per day, if you give the patient 600 milligrams, after 2 dosages, they're at that maximum level. And what happens next? So 400 milligrams is my recommendation, is my go-to. 400 milligrams of ibuprofen and 1,000 milligrams of Tylenol. And we'll come back to this when we're talking about office protocol, because that's one of the part of the reasoning how we came up with the dosages and the medications that we're using for our office protocol. If we look at the at the studies, and this is a recent one that was published in Annals of Emergency Medicine in 2019, when they looked at the acute pain management for patients who presented to the emergency room, they found that there was really no significant difference between analgesic properties. Again, we're not talking anti-inflammatory, analgesic properties between 400, 600, and 800 milligrams of ibuprofen. We started talking about Exparel, which is a local anesthetic bupivacaine in its liposomal form. And as I alluded to earlier, it's been available since 2016. They did initial research on hemorrhoids and eventually was FDA approved. It's some oral surgery practices using it. I don't know if it's very common in periodontal practices. Essentially, it's bupivacaine in its liposomal form. It's infiltrated at the surgical site upon completion of the surgical procedure. And dispersion of this local anesthetic is fairly poor because of its liposomal form. So multiple injections are required at the surgical site to obtain good anesthesia in the area. And one of the concerns is, or not concerns, but something that clinicians should keep in mind when using Exparel is the additive effect. So if you have local anesthetic already on board that you use for your surgical procedure, you have to factor in how much local anesthetic you use and add the bupivacaine, so you're not over the limit as far as how much local anesthetic you're using for the particular patient. It will provide up to 72 hours of anesthesia. So it could be good and bad. If you're doing a connective tissue grafting and patient is not really kind of feeling that area, will they be more likely to injure it. It's a point of debate, but it does have, in my opinion, some place in oral surgery. It's kind of cost prohibitive for a lot of procedures. If it's a minor procedure, it adds it adds about $325 to the clinician cost for each case, but nevertheless, it's available. Still Life Recovery Kit has been on the market since 2016, and it's a combination of 14 different botanicals that are combined together. Its action is designed to decrease inflammation, accelerate healing, and provide analgesias as well as antimicrobial properties. The 14 active ingredients, they're plant-based and some mineral-based, have been around for a number of years and have had a long history of efficacy and safety. And they've been selected for their anti-inflammatory properties, analgesic properties, properties that have been shown to accelerate healing, and some antimicrobial properties as well. So in one kit, essentially, you have pretty much all you need for your post-surgical care. The gel and the rinse that come in a kit, the gel and the spray are the two, have similar content. They have 14 active ingredients. The spray is used in the sublingual fashion. It's sprayed under the tongue and gets absorbed through the sublingual mucosa, and the gel is applied at the surgical site. So essentially what you're getting is a central action and peripheral action of those 14 active ingredients. The rinse is, as I alluded to, antimicrobial rinse. According to the manufacturer protocol, it's recommended that patients are started 3 days preoperatively. And there's a couple of reasons for that. Number one, you're getting a therapeutic blood levels when you start 3 days before the surgery. The surgical site will, a lot of times you'll find, has decreased inflammation during the surgery because the patients already are therapeutic and have been using it for 3 days. An added benefit also is antimicrobial mouth rinse, which decreases bacterial load in the oral cavity preoperatively. And another added benefit is that the gel and the spray have an active ingredient called Ignatia, and that's been termed homeopathic or natural Prozac, and is known to decrease anxiety. So you have at least one active ingredient that is designed to help decrease anxiety both preoperatively and postoperatively for your patients. When we analyze and we look at all the active ingredients, and remember, we're reviewing just the active ingredients by themselves and the action that's been researched over the years. There is an additive effect of all 14 active ingredients working together. So there's a synergistic effect that's making the final product a lot more potent than the essentially combination of all the active ingredients by themselves. If we look at the arnica, some of the research have shown that it decreases the inflammatory factors such as TNF-alpha, interleukins, and nitric oxide. It also works, been shown to work indirectly by stimulating macrophage cell line that's differentiated to wound healing, thus indirectly helping with the wound healing. Acanthium has been shown to work pretty much just like our local anesthetic through the sodium channels. One of the alkaloids of gilsenium, which is called cumin, has been found to have anti-allergenic and neuroprotective effects. It's also has been recommended by a number of studies as a use for diabetic neuropathy, which is very difficult to treat. Gilsenium has been shown to alleviate neuropathic pain and sleep disturbances. Chamomile, another active ingredient, has shown the efficacy similar to local anesthetic, working at the sodium channel, through the sodium channels. Chamomile exhibit actually selective COX-2 inhibitors, similar function to the selective nonsteroidal anti-inflammatory medications. In a double-blinded randomized control study, chamomile was found to be safe and well-tolerated effective treatment for women with moderate nostalgia. Calendula, which is another active ingredient, has been found to have efficacy for diabetic foot ulcers as well as venous leg ulcers. So when it comes to the pain management of our patients, I think it's important to make sure that when we're going through preoperative or postoperative instructions with them, that we're on the same page. If we just simply tell the patient, take this pain medication 3 times a day, we're really not communicating effectively with the patient. Because as we know, preemptive analgesia is an important concept that can be quite effective. And also knowing for the patients to know exactly when to take the pain medication is absolutely essential for adequate pain control. We have it as part of the postoperative instructions or preoperative instructions actually too. In the folder, the patients get the instructions for pain medications. They also get this visual analog scale, and it's really makes it much easier for the patient to understand and know exactly when they need to take their next dose of pain medications. I always tell them on the scale from 0 to 10, you rank your pain. If it's at 0, no pain, 10, the worst pain you can imagine, at any point in time, your pain has to be 5 and below. If you're letting it get to 6, 8, and 9, it's much harder to control the pain at that point in time, and it will require a lot more pain medication. So if you are not using a visual analog scale in your practice, I would definitely recommend to incorporate into your postoperative instructions. It will improve your communication with the patients. And also if they call you and tell you, doctor, you prescribed this non-opioid regimen and it's really not working, the first question is, at what time did you take take your last pain medication, what it was, and at what level your pain was. And then it makes it much easier for you to instruct the patient how to get their pain under control. This is a study that was published in the Journal of American Medical Association in 2018. As it always is the case, whenever there's a crisis, we have to find a guilty party. And in this particular case, they found dentists as a scapegoat for opioid crisis. So what they did is they looked at retrospectively a cohort study. They looked at their database and pulled the information on patients between ages 16 to 25 who underwent or had dental procedures and were prescribed opioids. They pulled it by national provider identifier, which was correlated to the dental license. And so they analyzed the data and concluded that substantial proportion of adolescents and young adults are exposed to opioids through dental clinicians. They further went on to say that use of this prescription may be associated with an increased risk of subsequent opioid use and abuse. Whether or not you look at the study and say, okay, well, maybe it's biased, dentists are, being blamed for something that really they shouldn't be blamed for. The question remains, can we, in our dental practices, whether it's a general dentistry or a specialty practice, reduce the opioid prescriptions without, especially heavy opioid prescriptions, Schedule II opioids, without really compromising on patients' pain level. And that's the question we kind of asked ourselves a couple of years back. We did a retrospective analysis and published in 2019 in the Journal of Oral Maxillofacial Surgery our findings. So what we did is we did a retrospective cohort analysis. We looked at the patients that were seen at North Shore Center for Oral and Facial Surgery in that 3-year interval. And all the surgical procedures were performed by single surgeon in 2 different locations. As an inclusion criteria, we included pretty much all the procedures that usually require or warrant opioid prescription. That's impacted wisdom teeth removal, your complex bone reconstruction, full arch reconstruction, dental implants. We excluded procedures that routinely don't require usually strong opioids like biopsies, or not giving strong opioids like biopsies, routine extractions, cosmetic procedures, and we also eliminated orthodontic surgeries from our procedures that we're looking at. So the primary predictor variable was introduction of office protocol, which we're going to discuss in just a second. The primary outcome variable was filling of strong opioid prescriptions, which all patients were given, that was correlated with the pain control as assessed by the patient. Age and gender distribution were analyzed, and we also look at the proportions and associated 95 confidence intervals to get the statistical analysis. So in March of 2016, we introduced the office protocol, which we call the office protocol, designed to optimize preemptive analgesia and to use non-opioid options such as NSAID and acetaminophen for post-surgical, post-operative pain control. So we start the patients on Vega Recovery Kit as recommended by the manufacturer. We start 3 days preoperatively, and then the patients will continue 7 days post-operatively. At the surgical site, immediately after the surgery, we apply Vega gel. So we're getting anti-inflammatory. Remember, we have our peripheral function of the Vega gel that we're optimizing on right away. And when the patient is recovered in the recovery room or in the operatory, we give them 1,000 milligrams of acetaminophen and 400 milligrams of Motrin immediately post-operatively, while the local anesthetic is still working, is still in place. So we're optimizing on preemptive analgesia for pain control. We looked at so the number of patients that we analyzed, we pulled from the management software using the CDT codes. We also looked at we analyzed data from the same period of time of patients who actually went ahead and filled the prescription of heavy opioids in that period of time that were issued by our office. We use Illinois Monitoring Service. I happen to live in the state of Illinois, so this is kind of a portal, what the portal looks like once you log in. Pretty much every state now has a similar website, and I would encourage you to, if you haven't registered or if you haven't checked your portal in a while, to go ahead and log in and look at your history of opioid prescription. You can go back about 3-4 years. And with a special request, I think you can actually get even history that's going even further back. But it could be an eye-opener for a lot of clinicians. You may think that you're not really prescribing many opioid, but once you actually stop and analyze the data, you may think differently. So speaking of the results, we looked at a number of procedures that fulfill our inclusion criteria. And they were about the same from 2015 to 2017. The 2017, we saw slightly more male patients, and the patients' mean age was a little bit younger. But in conclusion, what we did in 2015 is, based on our analysis, 59% of adult patients between the age of 15 to 85 who underwent underqualified surgical procedures that were part of our inclusion criteria required and filled heavy opioid prescription. In 2016, we introduced office protocol for pain management designed to reduce opioid use. And in 2017, that number fell to 19%. So we effectively obtained a 3-fold reduction in the Schedule II opioids in a 2-year interval. I can tell you that once we had a proof of concept, and I felt confident that we're getting adequate pain control with our office protocol. In 2019, we completely eliminated Schedule II opioids, and I'm very proud to say that for the last 2 years, we have not prescribed a single opioid that was Schedule II, and very occasionally we prescribe a Schedule III opioid for breakthrough pain. A similar study, similar findings, a little different study was performed by Dr. Cameron Lee. renowned oral surgeon out of Hawaii, and Dr. John Suzuki. They looked at prospectively at patients undergoing unlaid bone grafting in Dr. Lee's practice. They have two groups. One group post-operatively was given the non-opioid option and prescription for opioids, and were instructed to only fill that prescription if the pain was not adequately controlled with a non-opioid option. And their non-opioid option essentially was very similar to our office protocol. It was an NSAID, acetaminophen, and cell life recovery kit. And what they found was that the pain management was much better in the group was that had no opioid or opioid-free regimen, and therefore they concluded that it definitely has a huge place in pain management of their patients. This is a clinical case that's kind of that I wanted to include to illustrate a point. Something that most of you probably see on a regular basis in your practice. The patient comes in with failing lower dentition. We're going to extract the remaining lower teeth and do our full arch rehabilitation with 4 implants and immediate temporary prosthesis. And when the patient, usually see those patients a week for post-operative evaluation, and just like with all our patients, he was placed on office protocol for pain management. And when he came back for follow-up, just like I see with most of my patients, he was raving about pain control and was very happy with overall pain management. And we started talking. I said, one of the reasons that we're eliminating the opioids, and he said, Doc, I completely understand, and I appreciate what you're doing. And then he pulled out his phone and he said, I wanted to share with you something. And he showed me this picture, and with his permission, I got a copy of it, and said, do you mind if I use it in my presentation? He said, no, absolutely not. So this is basically a number of bottles here with a lot of medication that this patient was prescribed in a course of 6 weeks, about a year prior to his presentation in my office. He had some neck pain going through a divorce. So he went to his primary care physician. He was depressed and kept complaining about neck pain. So the primary care physician kept giving him these prescriptions. I said, Doc, I never took any of them, but I put them in my medicine cabinet, and about a year later, I opened my medicine cabinet and I kind of lay them all on the counter, and I took a picture. So when I took a look at those medications, the primary care physician in the course of 6 weeks had given the patient 220 tablets of ropoxyphene, about 40 tablets of benzodiazepine, muscle relaxant steroids, and non-steroidal anti-inflammatory medication. Could be a dangerous, really, combination for a depressed individual, but astonishing number of opioids and benzodiazepines given to the patient. More news on opioid overprescription. This particular physician that was apprehended prescribed 500,000 opioid tablets in 19 months. I wonder how many of those patients were between the age of 16 and 25, but just kind of illustrates the point that our medical colleagues, all of us in healthcare, should be aware and conscientious of opioid prescription, what we give the patients, and the consequences that it can create. So we started kind of with this flow chart with the discussion on the pain management that's available right now in dental practices, and I'd like to add one more line, 2016 new model, and that's based on the office protocol. Use of non-steroidal anti-inflammatory medication, acetaminophen, and a cell life recovery kit, and given patients for more advanced surgical procedures, a script for tramadol for a breakthrough pain. And that's all I have.
Wow, that was great. I'm going to unmute everybody, if I can, like to hear some questions. Or I did have a question. I may have. It's been a long day for a lot of us. I see that you're using 1,000 milligrams acetaminophen with 400 milligrams of ibuprofen. Is that about every 4 hours or 6 hours?
Right. So we don't want to. Right. So it's 4 times a day. So it's every 6 hours.
Okay. And oh, I muted somebody, wrong person. Um, anyway, as far as start, do you start that at the procedure? Do you ever start it the day before? What's your protocol? May
Uh,
have missed that.
I don't really find the efficacy of starting it before the surgery, but we do give the first dose immediately post-operatively while you still have the local anesthetic on board. And the concept of preemptive analgesia I think, is extremely important. And going back to our patient instructions too, we want to manage the pain when it's at 4, 5, or 3 possibly, and not at 7 or 8 or higher, because it becomes much more difficult.
We've been using Stella Life, I'm going to guess about 5 months now, and we seem to see really great results with it as well. Are you continuing patients, depending on the procedure, on any of the products after the initial regimen? And if so, can you?
Absolutely. The oral rinse, especially with my implant patients, I mean, they continue using it. They're swabbing at with the Q-tip impregnated with Stella Life rinse around the healing cap. And they continue using, they incorporate it in their daily regimen after the implant is restored. So my recommendation is what we recommend for daily maintenance is that rinsing is wonderful, but taking a Q-tip after the implant has been restored and just they kind of massage the area of the cervicogingival junction for about a minute on either side, on the lingual and the palatal or buccal and lingual sides around the cervicogingival junction. And what I believe it does, it actually stimulates it expresses the stuff that gets trapped in the pocket, and also allows for the direct delivery of the Stella Life rinse right at that cervicogingival junction.
Any other like procedures like biopsies or like implantus or any other areas that you're finding it useful?
Absolutely. I mean, for when I'm doing biopsies or connective tissue grafting, to be honest with you, as far as and I'm one of the rare oral surgeons that actually does connective tissue grafting in the office. I know it's a big no-no, but I do them. I enjoy them. So. My go-to is we do a 4 amoxicillin or 4 clindamycin, depending on the patient's allergy, 1 hour preoperative, and we don't give any more antibiotics, and just the Stella Life recovery kit for postoperative management. As far as biopsies are concerned, you could do the entire recovery kit. The gel is actually available separately too, and that you can add the oral rinse, and a little bit more economical for the patients. But if you're doing minor biopsies, some of the biopsies we do is enucleation of cysts and things like that. I mean, that's definitely warrants a recovery kit. But if it's a minor tissue biopsy, I think the gel and the rinse will serve you very well, and will allow for a really accelerated healing for the patient and very good pain management. The lichen planus, I can tell you anecdotally, we don't have any studies to support it, but a lot of clinicians throughout the country have reported good management, especially erosive lichen planus, which could be very painful for the patients. And the rinse and the gel combination have been working very well. They're certainly safe to use long term. And the alternative is our Lidex, our topical steroid that carries tons of side effects. And so for maintenance, I think it's a wonderful combination: the gel, the Stella Life gel, and the rinse to use for patients with autoimmune conditions. Again, I don't have any studies to quote, at least at this point in time.
In the past, and we still do use chlorhexidine in our practice. I don't know if you've seen a big difference or if you use chlorhexidine, gluconate versus the Stella Life rinse. I'm just curious what your personal take is on that.
So, Alan, it's a great question. Thank you for asking it. Yeah, I can tell you that, I mean, for years we've known that chlorhexidine has chemotactic properties. I mean, it kills fibroblasts, it slows down fibroblastic activities, it kills osteoblasts. And to use it in the oral cavity, it is absolutely has antimicrobial properties. There's no question about it. But I can tell you that. It probably should not be used as a maintenance, especially if it has anything to do with bone and bony healing, because it always surprises me, when in oral surgery and general dental community when discussion about bisphosphonate-induced or medication-induced osteonecrosis of the jaw. When you have exposed bone, you put the patient on the oral rinse, which kills more bone. So, I mean, eventually the body kind of heals it because it's all necrotic bone. I'm yet trying to kind of understand the reasoning behind doing that. So, in general dental practice, I think that chlorhexidine has in my opinion, minimal application and potential a lot of side effects. There's a number of studies that will be coming out shortly that looked in vitro at different rinses, and I don't want to give all the secrets away just yet, but I think it's going to be a game changer when it comes out, really showing what the healing, kind of diving in on the cellular level and looking at the healing when cells are immersed in chlorhexidine versus, in this case, we're talking about Stella Life oral rinse.
A couple of questions on the chat. What is the cost of Stella Life kit per patient?
That's a good question. My front desk is dealing with it, so I can't tell you for sure that I know. I think it's about $80 some, 89.
I think so. I think it's maybe 90 if they buy it online or by you. I think that's what we get it for. We sell it for something like that. And I think the rinse is $24 a bottle, something like that. And then I believe dentists get 30%. We get 30% off that.
Absolutely.
And there's another question. Somebody said they've never really heard about the contraindication for healing of bone. Do you have any references? And I have heard that and read that. I don't remember the articles.
Absolutely, I have a litany of articles that I can share with you. So if you'd like, I can definitely send the articles your way. Absolutely.
Yeah, and I'll post it on our website. That'd be great.
Absolutely, would love to. Yeah. And I can tell you another thing is, if you have exposed alloderm, of course, none of us ever get exposed alloderm, but if we ever get exposed alloderm for connective tissue grafting, if you put the patient chlorhexidine, it's the last thing you want to give the patient.
We've been using it with people that have dry mouth issues as well in my practice.
Absolutely.
How's your compliance? Patients very compliant with the product is another question.
Well, you have to explain. I think so. For years, we've trained the patients to expect some opioids, right? I mean, their biggest concern is they don't really. I mean, most of them, unless they have abuse history, they don't really care if you give them opioids. You don't give them opioids. They care about pain management. And if you take your time and tell the patient that their pain management is the uttermost importance to you, and you're going to be there every step of the way, and explain the rationale for using different medications and Stella Life recovery kit. I can tell you that in my practice, I've been recommending arnica in the pill form 15 years ago because of some of the experiences I've had in cosmetic and plastic surgery. I mean, plastic surgeons have been using arnica bromelain plant-based product for years. In fact, a lot of studies have come out from a lot of them have published in annals of plastic surgery, have shown significant efficacy of just arnica by itself on rhinoplasties, rhinodectomies, and decreased edema, decreased bruising after surgical procedures. So it has to do, and what I find, or what I find on a daily basis, and have seen for many, many years, our patients are seeking for alternatives. They don't want to be given opioids. They want to safe alternatives. They're going to do the job. And I can tell you that the patient's coming back and raving about it. And that's the biggest compliment to you and your practice. If your patient's coming back and saying that was great, this doctor is at the cutting edge. He's offering and to us as patients the best that's available out there. And when the parents come in, we take out, obviously, part of our practice, wisdom teeth. We take out, when mom come with their kids for removed wisdom teeth, and we say, we're trying to minimize the opioids. I mean, their eyes lit up. It's everyone is talking about it, and the teenage population is probably the last people you want to be prescribing opioids, yet you want to control their pain adequately.
I have not received any complaints as far as taste or any actually reactions. I have had patients react to chlorhexidine, some burning mouth, other possible allergies to chlorhexidine. Have you experienced anything like that in your practice? Any sensitivity or allergy, possible allergy to the product?
Well, I stopped. Are you talking about chlorhexidine or the Stella?
No, more the Stella Life. That's
Okay.
some of the questions we got were regarding that here.
I have not had any issues. I mean, if patients are allergic to any part of the active ingredient, certainly we don't want them to use it, but that's very rare. Mm-hmm. I really haven't had any problems. There's no staining with Stella Life oral rinse, and before using it on our patients, we've tested it. We have a lot of free floating teeth, so we put a couple of them in the Stella Life rinse and kept for up to 72 hours and didn't find any staining. So that was gave us a good feeling that it's gonna be fine on using in our patients.
Couple more questions. One comment: nice presentation. Do you follow the same protocol in case of post-op infection, or would it change?
Post-op infection. So, are we talking any particular procedure, or?
It's not really written here. I'm reading off the chat.
The answer is yes, absolutely, because you want to have the antimicrobial properties, no question about it. My regimen for antibiotics, something that wasn't part of this presentation, but I'll share with you. Anyways, we do loading dose, and that's based on a number of studies. They looked at a week pre-op antibiotic, 1 hour, 1 day pre-op, and then continue for 7 days. And they found the biggest efficacy is that loading dose 1 hour before the surgery, as far as reduction of the infection. So we do use the 2 grams of amoxicillin or 600 of clindamycin, patient allergic to penicillin, preoperatively. And then I usually put them on 1 or 2 days of antibiotics, to be honest with you, for most of the cases. I mean, if it's a patient who is diabetic, who's A1C is 10, I'll probably keep on antibiotics for 4 or 5 days. But general population, ASA1 healthy patients, I probably would do 1 or 2 days worth of antibiotics. So to answer the question is, I would still continue with the same regimen, no question about it. Antibiotic is clinically necessary.
Last question I have so far is, and if anybody has any more questions, we're coming upon our hour. Why is healing faster?
So there's a number of different factors that are at work. I'll be more than happy to provide you the studies, but there's 4 or 5 different active ingredients that are known to speed up the accelerate the healing and speed up the healing. And there's actually in vitro studies that are coming out. Again, I don't want to give it away, but
oh, come on. No, I'm kidding.
We'll have the proof is in the writing, so we'll see it in the in vitro study. But to answer the question, some of the active ingredients that have been known to accelerate healing.
So if you could email me, this information, I could share it on our website. And we're currently working with Stella Life to have a web page on our online community site with them, so we'll be able to put these future articles on there. And any other questions from anyone, you could unmute yourself if you're not too tired, or hit the chat. And if not, I'll give that a couple of seconds here. Is another question, is it safe to use the gel during surgeries, and how do you use it?
The gel that a part of our protocol is we apply immediately at the surgical site with a Q-tip, and the patient instructed to do the same post-operatively. I know I've talked to some of my periodontal colleagues, and they're always nervous about patient using a Q-tip in the area. I haven't found it to be a problem at all, and I can tell you that what did it for me as far as the clinical efficacy is we do a lot of just happened in my practice. We do a lot of full arch cases, and it's with immediate loading, and patients are finished with surgical procedure. We take impressions, and there's always about 40-50 minute lag time when the laboratory technician is fabricating the temporary prosthesis. So we applied very generously gel at the surgical site. And this is kind of a unique opportunity for us to kind of bring the patient back 50 minutes, an hour later, and take a look at the tissue. And it is truly astonishing what the tissue looks like in that 50-minute time interval between the application and 50 minutes later. The patient continues. I personally don't have any problems with patients using it topically again with a Q-tip carefully. I have not, knock on the wood, I have not had any problems with anyone displacing the suture. And we instruct them how to do it. But you're at mercy of the patient when it comes to post-operative recovery. I mean, give them instructions about the brushing, instruction about everything else. And as long as they're following your instructions, everything should be okay.
All right, that's really it. I just want to say, and I'm not being paid by Stella Life for tonight, so that's my disclosure. But we've just, we're a pretty new adopter with the product, and I speak to a lot of periodontists across the country, actually internationally, and I've been getting personally some very good results and good feedback from patients, and so it's something that we're going to be using more and more. We did incorporate using ibuprofen with Tylenol as well a while ago, and that's very beneficial. I don't see any more questions. So some of the people are asking, are you using it? How's it working for you? And a few people have said, I have it in my office and now using it during full mouth rehab consistently. So that's to everybody in the chat. So I think we're going to see more and more. I like the fact that it's a natural healing product. We have a lot more patients that are looking for that. We've personally reduced antibiotic use as much as we can. I think that our country uses more antibiotics than the rest of the world put together, I believe. So
Ellen, if you can interject for just a second,
sure.
to the point of using it for full arch cases, there's actually a video that's posted on the Stella Life website, so I would encourage you clinicians to visit that, and it shows in details how we apply the gel immediately post-operatively and shows what the tissue looks like 50 minutes later.
I don't know if I reached out to them and I got a lot of emails back, but I got so crazy with COVID and practice that, a lot of talk's been about rinses and pre-rinse now to reduce aerosol. And there's been a lot on hydrogen peroxide use and
Right.
other iodine rinses and Listerine. I don't know what your take is on that, if you don't mind sharing your personal.
I never like hydrogen peroxide. I think it could be too abrasive to the tissue. We're talking, ultimately we're talking about if we're talking about COVID-19, we're talking about viral properties, right?
Right.
So if we look at the 3 out of 4 active ingredients of the Stella Life rinse, there's some efficacy against viruses. Herpes simplex virus among others. And I mean, obviously, we don't know, right? I mean, if we're targeting antiviral properties, I think probably stelliferins would probably make more sense to use than hydrogen peroxide, although it could kill very well viruses. So I don't have really, there's no studies. I can't really quote one way or the other. I think it's the virus starts in the nasal passages or is seated in the nasal mucosa and in the posterior pharynx. And so I think that for us as clinicians, I mean, I'm seeing emergency patients every day, kind of the front line there. And I routinely gargle with stelliferins. I don't know what the efficacy, but for this particular problem, but it's I think we can't be overly careful with especially the current situation.
If you do hear of any studies being done about the if they studied against COVID and you get that, please share that with our members and me.
Absolutely.
Appreciate
and
it.
also, I'd like to say that you can go ahead and share my email with any of the clinicians who are listening. If they have any clinical questions or clinical case they wanted to run by me, they're more than welcome to email me anytime.
Sounds great. That's past our hour, and I want to thank Walter Tatch for taking the time to be with us, and the people at Stella Life for a great product, and everybody on tonight for after a long day for many of us for being with us. For those who want to join us tomorrow at 12 noon Eastern, we have a guest speaker, Dr. Mark Cooper. It should be an interesting hour, and have a great night and be safe. Stay healthy. Thanks a lot again, Walter.
Thank you, Alan. I appreciate the opportunity, and for everyone, please be safe.